Okay, it seems to be working.
It's working?
Yeah.
We are live. Roman, could you put...
But this is what you get, right? So
Let me see here.
probably need to sit back, but the problem is I want to
Is
get
there
the
sound
audio.
as well?
Yes. And volume is.
Could you put a little thing on our website?
Yes, yeah.
So people can...
Once this works. Oh, she has a cable. Great.
Perfect.
Thank you very much.
Yeah, just go over to... How's that little thing? That's Brad.
We can put it under the table. Because I'm afraid we'll move it even further down. Move the right. There we go. Hold on. This back. What is it? Right, yeah, there we go. Thank you.
Okay, we'll start in about 1 minute.
I think. With Dr. Pitlick.
I'll keep my remarks
To a minute.
It's been a pleasure to meet people, several of you for the first time in person. We've all known each other for a very long time virtually on the wonderful website known as Life.
You need the space. It's like a little If you want to come over here.
I'll put here. Just like that.
Good to see you. Yes, good to see you. Good plan.
Is it not getting power or something?
I think it needs some time to shut down. You can pass me that. Thank you. Thanks. Oops. Startup.
Very good. Just gonna warm up a little bit.
All right. Well, it's good for you.
Outstanding. I think that's the effect of the beers last night. I'm sure it's crystal clear.
It will be in a second.
It's cheaper to go into the.
Let me get the mic.
Okay, are we, Roman, we're ready?
Yes, we've been recording. Just a minute here. Put it like this. Perfect, yes. So,
Welcome. I have no gavel, but Weiss 13 is officially opened, although I believe it opened last night. I'm so happy to welcome you to my home institution, Adrian College. Many of you made quite an effort to come here and have traveled from long distances, and I'm very grateful that you did so. The first mention of Adrian College on the Weiss forum was I actually found it this morning, was in November of 2000, when Professor Hilton introduced me to the group. That's when I joined Weiss. And he wrote at the time that he had never heard of Adrian College or Adrian, Michigan. But Professor Hilton went on to write in great detail about how this city was founded in the 1820s and named after the Emperor Hadrian. And said that, there are many, many fine institutions in the United States, and Adrian was one of them. Fine, small, liberal arts institutions. So I'm very, very happy to bring you here to my city. And Adrian has, some historic importance. For example, this is the birthplace of the great industrial designer and futurist Norman Bell Geddes. The chain link fence was invented in Adrian, Michigan, and there was a very, very important company called the Page Fence Company that sponsored in the 1890s a team in the Negro leagues of baseball. And the Page Fence Giants were a baseball powerhouse known throughout the nation in the 1890s, and they won the Negro Leagues championship in 1896, and in 1897 they had a 62-game consecutive winning streak, which is quite important. I'm sure you all remember Home Run Johnson. He was one of the founders of the Page Fence Giants. So enjoy. The weather has been just outstanding and will continue to be outstanding through tomorrow, when we'll enjoy a football game in the afternoon between the Adrian College Bulldogs and the Scotsmen, who are coming from Alma College, which is a little bit north of here. So we're running a little behind, and we'll try to stick to the schedule. Our first presenter is my good friend, Dr. Paul Pitlick, who is a pediatric cardiologist and is an emeritus professor at Stanford University, and continues to practice in Albuquerque, New Mexico. And Paul will be speaking to us. Oh, he's also a member of the Weiss board, and I must say is one of the unsung heroes of Weiss. Paul has done so much to help our organization thrive, and I'm very grateful to him, and to his wife, Jan, who is also a good friend and a good friend of my wife, Alana. Paul will be speaking on the Affordable Care Act, and I presume some of you have heard of it. We call it Obamacare now. Originally, there was about a year when I wouldn't allow the term Obamacare on
on the Weiss Forum, unless it was a direct quote. But President Obama himself is now embracing the term Obamacare, so it's stuck. And we can use it now. It's no longer fair bulletin on the forum. But without any further ado, I would like to introduce Dr. Pitlick, Paul Pitlick.
Thank you all for being here. Thank you, John, for setting us all up. This is, glad to get everybody on. Hope this is loud enough. I guess there's not a speaker, but John alluded to the Affordable Care Act versus Obamacare. There's a little bit we don't have a TV at home, so I don't watch this stuff, but online there was a thing. One of the gyms, there's a Kimmel and somebody else, have a late night show. And they went around, a little bit, okay. They went around talking to the man on the street about what they felt of Obamacare versus the Affordable Care Act. And of course, they could edit out whatever people said, but what they showed was, people say, oh yeah, the Affordable Care Act, that's good for everyone. We all need affordable care, but Obamacare, that was terrible. Terrible. Worst thing anybody ever invented. And when one woman was told, well, they're the same thing, she said, oh, you're lying. I don't believe that. So we'll start talking. Also reminds me of a video show I was driving someplace a while back. There was a man interviewing an author who wrote the book about men my mother met. And one of them was Jack Kerouac. This is the 1950s. And the interview said, well, are these true stories? He said, really, two of them. So, on the basis of that, I'll start talking about this. So the Affordable Care Act, why it was, how it came into being, and we'll talk a little bit about some of the myths associated. There's a lot of misinformation going on. So why would anyone want to talk about reforming health care financing? Cartoon of doctors talking to the wife, I don't know if you can all see that. Doctor saying he was doing well at first, but then he started drifting in and out of health insurance coverage. So, small print here, so I increased the site. John, this I'm a physician, I'm also a patient. Many of us in this room probably, some of you may have exactly the same things I have or have had. Prostate problems, sounds familiar, but I will thanks for showing hands. Arrhythmias, something like 5 million people in this country over the age of 65 have a certain type of arrhythmia, which I happen to have. So those are unimportant, except to say that I've also had to see a physician myself. So to start the conversation, I thought I would talk about what's called explanation of benefits. This isn't a real bill. I don't receive the hospital bills. I'm on Medicare. Medicare gets the bill, but I do get a report of what was billed and what they paid. So here's one sample. Again, small text down there. You can see the bill was about $8,500, more or less. You can see that. I've left off the dates here because I'm going to have a little audience participation. Left off what actually was paid by Medicare. Another bill, this is for my prostate surgery. You can see here it's $90,000 plus. Again, interesting things on these bills is here's hospital miscellaneous, $29,000. Hospital miscellaneous, $146. Just random stuff I had no idea what those things were, but this is what I saw. And this bill here, $145,249.70. Okay, audience participation now. Quiz, 2 questions. Well, actually, I guess 6 questions. How long was the hospitalization? I mean, what did I get in my 84,000? Medicare's 84,000, etc. And what was the hospital paid? This is what was billed. What were they paid? So, show of hands or comments. Anybody want to talk about what do you think this bill? How long was that in the hospital here? What was the reimbursement?
One of them was totally inpatient or outpatient. One of the first bill you showed, I think, was for totally outpatient.
So how long was that?
Hours or half a day, less than a day.
Yeah, 4 hours.
4 hours.
Okay, $8,000. What was the reimbursement?
About 15%.
$500. Okay. So $8,000 billed, 5% actually, for 4 hours worth of care. Next bill, and I haven't selected these. These are, I haven't had 60 bills, and these are the worst 3. These are bills. $90,000. What's the length of stay? Any guesses? Day and a half. Other guesses? Okay. Wasn't that bad. It was actually, and then, reimbursement, let's talk about reimbursement. Any guesses on that? There was about 15 or 20% of this. So this was actually in the hospital 3 days. This was only $30,000 a day as the bill. That's not what they paid. Medicare paid $20,000. Blue Cross Blue Shield paid another $1,000. So the hospital was paid $21,000 for a bill of $90,000. And the third one, $145,000. Estimated for length of stay. Week. 3 days. 3 days. 1 day. $145,000 for 1 day. And the reimbursement, about 10% in this case. So they paid $14,000. Insurance paid $1,000. So a couple other questions we'll talk. What would I owe if I didn't have insurance? I mean, I have to have insurance. Good insurance, I have Medicare. Love Medicare. What would I had to pay if I didn't have insurance? Nothing. The hospital would have liked me to pay this much. They would have wanted $145,000 for 1 day. So it brings up, in my mind, just now speaking not as much as a patient or even a physician, but I often wonder what kind of a business model is it that you expect the people who are at least able to pay it a lot of money, and the people who have sort of deeper pockets paying somewhere between 5 and 20% of charges. I'm not sure. I'm not a business person, so I just think that's kind of a bizarre business model. I think it would be hard to plan to make it best. If you're running a hospital and you have these kind of variables, I'm just not sure how to do it. I was just an article in the New York Times about 6 months ago about a comment about how there's a wide range of charges that hospitals make for the same services. As they say, sometimes charging 10 to 20 times what Medicare pays for. And again, they accept that as full payment. There was another article that I heard you. I've shown these things. If anybody wants the data, I'll give you a copy of my talk. You'll have to check it yourself. There's an article from New Yorker about 4 years ago, the town of McAllen, Texas. Medicare keeps pretty good records of their services, what they pay, where it goes for, et cetera, et cetera. And the point of this article was that there are places where the doctors basically perform a lot more procedures on patients. And in the case of McAllen, Texas, they compared them to a suburb of Denver and Minneapolis. And the patients in McAllen were Medicare was being billed twice as much as these other patients, but the outcomes were different. And it turns out it's an interesting article because the physicians had conflicts of interest and the ethics were somewhat suspect, although it was an expert about it. So those were my bills. What happens on a larger scale? Here's on the y-axis are expenditures, health expenditures per person for the last 50 years. You can see in 1960 we paid $147 per person for medical care. Of course, those dollars were significantly more valuable than our dollars are. But it was 5% of our gross domestic product. 10 years later, that cost had doubled. Another 10 years later, it tripled from before. Another 10 years doubled again. Another 10 years doubled again. And now we're up to about $8,000 per person per year of expenses for medical care. Oh, I'm sorry, I didn't say that. As a percent of gross national product, about 5% to almost 18%. So on a larger scale, what this graph shows, again, expenses dollars per person per year. The numbers here are now 190 different countries. I think the CIA actually provides this data. You can get it from different places. This website actually is the Kaiser Family Foundation, which is a healthcare analysis place. And down here at the lowest country on this scale is Eritrea. I think they pay something like $10 or $15 per person per year. You follow out here. This is most of Europe and here, and the United States is up here. The next country down, at least on this graph, is a little less than 7,000. That's Switzerland. On another graph, they're slightly more, but you get the point. We're substantially higher than any other country in the world. I just shown that average expenditure is about $1,000 per person per year around the globe. And the median for the middle country, 95th country, they spend $500 a year on their citizens. well, it shows it's kind of lighting here, but this is the expenditures as a percent of GDP. You can see the United States here at 17% is the highest figure, that's this $8,000. European countries are somewhere in the 9 to 10, 11% range. You get down here to, say, the Middle East, maybe 4% per year, $600, $700, $200. And then this end of the table is sort of poorer countries in the world. You can see, although Sierra Leone pays 13% of its GDP for healthcare, its GDP is only $300 per person, so they spend $42 per person on healthcare. I took these numbers here from that little book. The Economist has a little handbook for the world in facts, and that's where these tables came from. Ran across this, I wasn't aware of this until I started getting this talk ready. But if you look at 5 different countries, US plus 4 European countries, again with our percent of GDP here, and the actual dollars we spend are dollar equivalents, obviously, in this column. What I thought was really interesting is that for the from the ages 10 to 50, we all have about the same expenditure, and it doesn't change much from year to year. We all have about the same healthcare needs as, let's say, adolescents and young adults, but things begin to diverge when you get to be 55 or 60, and in the U.S. that's especially prominent there. And again, I'm not a business person, but I would think if you just look at this cold hard numbers and dollars and cents and this big business, it probably would be pretty easy to have a business model here where whether it's government control, private insurance, something else, the more efficient companies are going to dominate the less efficient companies. It would probably be a pretty good business model. But what I think is unfortunate, personally, I've never heard this discussed anywhere, is shouldn't we in this time here be collecting premiums ahead of time so that when we get to the out here, we have kind of a bankroll that we can rely on? Wouldn't that be the way to do things? But we don't. In this country, we dump these patients in Medicare. You know, government socialized medicine, et cetera, et cetera. So the profits taken out here by the insurance companies and the expenses are borne here by the taxpayers. So the question is, okay, we spend a lot of money, what do we get? So I'm going to show you 3 graphs here. First is life expectancy versus healthcare expenditures. This is years life expectancy, so higher is better. The next 2 lower will be better, but for this one, higher is better. And so again, we have all these countries scattered out here. The U.S. again is the highest. We're here. The blue dots are females, the red dots are males, and you can see that men in this country average about 75 years of life, women a little bit more than 80. This is not really abstract, this is a slightly different way of looking at the data. But on the y-axis here, we have ranked the countries from 1 to 190. So 1 would be Eritrea, 190 would be the U.S., 189 would be Switzerland, etc. So this is the rank of life expectancy here, and this is the rank of expenditures per capita here. Again, U.S. is highest, Eritrea is the lowest. So here's the U.S. We stick out on the far right, and you can see a bunch of countries here actually have a higher life expectancy than we do. This is a plot of infant mortality versus health expenditures. What infant mortality is, the y-axis here, is the number of deaths under 1 year of age per 1,000 births. And Afghanistan is up here, it actually has about 10% mortality at their babies at 1 year of age. The U.S. is down here at, I think it's 5.2, something like that. And if you plot us in ranks again, remember this is 1 is the lowest and 190 is the highest. The U.S. is here. Again, a lot of countries do better. Of course, we're not too bad, but there are a lot of places that do a lot worse. There are a lot of places that are doing better also. And finally, maternal mortality is deaths of pregnant women per 100,000. This is, you can see Afghanistan again is up here. And you get down to the United States, it's about 2 per 100,000. So again, we do pretty well, but if you rank us by rank, again, mortality here, rank of mortality versus rank of healthcare, you can see there are a lot of places that do better than we do. So that's what we put in dollars and cents, what we get out in terms of some statistics we can use. So I thought I'd do just a little history of healthcare finances, starting back with, say, ancient Greece. There was a physician named Galen who actually wrote treatises about how you care for certain conditions, most of which, it turns out, by the Middle Ages, people realized they were a little more effective than doing nothing. There was a financial system, but most of this was kind of barter. I think maybe you traded chickens for leeches or something. I'm not sure how it works. But eventually this evolved into a fee-for-service. Doctors provided a service, they were paid by patients. But medicine was mostly based at home. The patient got sick, the doctor went to the house, saw the patient, etc. Starting about the early 1800s, hospitals were coming into existence. But it was pretty well recognized that if you were sick, you really didn't want to go to the hospital. Especially if you were a woman who was going to get hurt, you really didn't want to go to the hospital because they had no knowledge of germ theory, no knowledge of cleaning your hands, washing your hands. So they'd go from one woman delivering a baby to the next woman delivering a baby. No sterile technique. So if the first woman had some kind of disease that killed her or her baby, the next woman may also die. So hospitals were not a place to go. But sort of by the late 19th century, early 20th century, with the evolution of the knowledge of germs and microbial theory, with the development of anesthesia in the 1860s, and sort of a more science-based approach to medicine, and understanding how surgery can be beneficial, hospitals became more prominent in the healthcare picture. In 1910, a man named Abraham Flexner was hired by the American Medical Association to evaluate the status of American medical education. He was not a physician, not even a scientist, he was an educator. Actually, he ran his own college. And he reviewed every medical school in the country, which there were more than 150. And his standard was Johns Hopkins, where they had an academic approach, science-based approach. The physician educators were scientists as well as clinicians. And he compared how schools did compared to Hopkins. And in his group, there were only about 10% of them who felt really past muster. The rest of them could be closed, although he didn't recommend closing them all. But he did recommend closing all of the 40 medical schools. So the 150 schools, about half of them did close over the next few years. And the others began affiliating themselves with universities. So the result was we ended up with better trained physicians who actually could do more. Patients did better, but there were fewer. So it's a market phenomenon. You have a better product, but fewer physicians, what's going to happen? Prices go up. So eventually, there was insurance in the early 20th century, but I wasn't around then. But apparently, insurance was used to replace income rather than for healthcare specifically. So if a man got sick, couldn't go to work, at least he had something for his income. But they didn't actually use the insurance to pay for his healthcare. And in 1919, as an example, insurance payouts to replace wages were 4 times the amount of insurance that was paid out to actually treat the illness. So another 10 years, 1929, with rising costs, again we talked about fewer physicians, a group of teachers in Dallas contracted with Baylor Hospital to provide hospitalization for the times that they needed that. And this eventually spread through the country, this idea. And eventually, as these things happened more and more, this became Blue Cross, which is still in existence today. 1934, since these plans covered only hospitalization and not patient services, the AMA developed some guidelines for how physicians can develop insurance. And that by 1939, insurance was being offered by physicians in some places, again, spread through the country, and this is the origin of Blue Shield. So in the 1940s, Blue Cross Blue Shield merged, and with the success of with Blue Cross and Blue Shield, insurance companies had been reluctant to underwrite policies for individuals. If I come in to see it's 1930, I come in to see the physician, to see the insurance company. How do they know I don't have TB or cancer or something? They really didn't have a way to treat individuals, but they realized eventually, with the success of these programs, that you could insure groups of patients and actually make some money on it. So they began issuing policies, and there were 10 million people who had medical insurance in 1940, and that number increased to 140 million 20 years later. So in the interim, what happened with healthcare financing? Insurance was more and more tied to employment. In 1942, the Stabilization Act put limits on wages. It was important to get people into these companies to provide munitions for the defense industry. They didn't have a lot of money for salaries, but they decided to start offering insurance as a fringe benefit to attract employees to their companies. And then decisions by the World Labor Board in 1949 and by the National Labor Relations Board in 45 here, 49 here, really reinforced the employment-based systems and allowed them to become part of union contracts. It was important for the auto workers here in Detroit, for example. In 1954, the IRS decided that medical insurance premiums were not taxable, which was again another incentive for work associated insurance. And then after Kennedy was assassinated and Johnson became president with the Great Society, Medicare was enacted for people over age 65, which at that time was a significant unmet need. And Medicaid was put into place, which was for poor people, and to apply for Medicare, you had to meet certain requirements for low income. But all of these things remain fee for service. In other words, the patient went in to see the doctor and with the hospital, a bill was issued. The insurance paid most of that bill, typically 80 to 90%, but the patient paid the rest. So starting about 1980 with the development of HMOs, health maintenance organizations, and preferred provider organizations, insurers began contracting with hospitals and physicians to reimburse the charges that the insurers felt were shortfalls. No, they got away from as you saw in my bills, it was the insurance company who decided what was going to be paid, not the hospital or the physician. And you may see on bills on your explanation of benefits the usual and customary charges, UCC. So initially these contracts were with individual hospitals and physicians, but the market response to that was hospitals, some of them did well, some of them didn't. A lot of merging of hospitals, the chains that developed began employing, control not just the hospitals, but began employing the physicians. Most states, I think, it's certainly true in California, that physicians can't actually work for the hospital. So when you see hospitals and physicians aligned, there's usually an umbrella organization that has physicians in one arm and hospitals in the other. Kaiser, for example, the physicians don't work for the hospitals. They have two separate chains of command, in essence. So, where are we now? Well, delivery of medical care is being consolidated into larger entities. Again, these huge practices. Insurance remains largely employer-based in the younger population with Medicare for older people. 56% of insurance is provided by employers. Individuals cover 6% of their own. Medicaid, almost 20%. Other forms of public insurance. And they're still 20% uninsured. The reason Medicare is not here is because this is for people who are not senior yet. This graph, a lot of information, but on this axis is expenses in billions, so this 3,000 is actually $3 trillion. And this is how much we spend on medical care per year. This is the growth here. As a function of how much we pay by different categories. So the green here is out-of-pocket insurance, Medicare, Medicaid, and this is other forms of public payment, military, Indian Health Service. And they include teachers here since they're often employees of a quasi-government organization. School boards are not private enterprises. So these are the absolute numbers, and this is the percent of healthcare. The same data as a percent. So you can see the percentage of money we pay out of pocket, even though it continues to rise, the percentage is falling. And insurance is paying more as a percent, but it's still less than half. Slightly more than half is being provided by public resources. This is a graph from Kaiser Family Foundation, again going back 25 years, 1987. Number of uninsured population, 30 million back then, and up to now, almost 60 million patients are not insured. And the percentage of people who are not insured these days is about 50%. So a non-trivial number of people. I found this graph, it's interesting. I was trying to get a better idea of quality. There's an article about improving quality in patients who have had heart attacks. The y-axis here is the deaths per 1,000 admissions, people who have heart attacks. And this slide happened to have, the point of the slide, the point of the article was that if you do certain things, you can improve care. And you can see how the mortality went down here every year. But what struck my eye was how these three curves here, this is private insurance, this is Medicare, Medicaid. They're more or less the same. But people who don't have insurance, you can see have about a 25% chance higher chance of dying. And in fact, it's estimated that something like 45,000 Americans who have treatable conditions die every year because they don't have health insurance. A couple of reasons for that: some of them are, say, homeless, have no money. But a lot of them who typically don't have health insurance delay getting care. They get sicker. It's more expensive to care for by the time they finally show up. They still end up with worse results. So, sort of to summarize where we are now, problems with the current system: we have employment-based health insurance, large number of uninsured patients. These aren't people sitting around watching television being found. 60% of the unemployed actually aren't working. They just have jobs that don't provide adequate health insurance. Patients with pre-existing conditions are often excluded from insurance, or they may be covered, their whole bodies may be covered except for the pre-existing conditions. So patients that I see, by definition, they have really pre-existing conditions. Oftentimes we diagnose their heart problem in utero, so even before they're born, we know they have problems. I mean, these are the ultimate in people with pre-existing conditions, and as they get older now, they're getting to be adults. They have trouble getting health care. Insurance finding ways to withdraw coverage when most needed. A woman, for example, who gets breast cancer, expensive treatment, the insurance company may go back to their records and they say, you had this, something happened before you were insured, we're not going to cover you anymore. Is it because I have breast cancer? Oh, no, it's not your breast cancer, it's because you lied to us on the forms. That's the point they need the most. There's an article in the New York Times a couple of days ago, I didn't have time to put it in here. They were interviewing 4 people who didn't have insurance and they had medical conditions. One of them was a woman who developed leukemia. She was in the hospital somewhere in New York City. Her bill was $800,000. Already she was still in the hospital. They didn't have to worry about being recovered, they just didn't have the money to pay for it. There are caps on lifetime coverage. Again, that woman's bill was $800,000. She could easily hit $1 million if she had insurance. It's possible they'd say, we're not going to pay for any more care. Sometimes arbitrary denial of coverage. They won't apply for some reason. Private insurance companies can have a high overhead. We'll talk about this in a minute. Their expenses may be 20 to 30% of the premiums that are paid in. Some of the executives have figured salaries in the high 8 figures. $70 billion is the salary of one of the insurance company presidents. That's compared to 3% overhead for Medicare. Bankruptcy is a problem. Something like 600,000 families will go bankrupt this year related to medical care, which is almost 2 million people. And another 50 million people have financial difficulties. They will go bankrupt, but they develop health care expenses and have trouble paying the bills. And another problem, a serious problem, is 5% of Americans use 60% of the resources, especially in the last few months of life. This article here, the hotspot is from the New Yorker. It's within the last year or so. Hotspots, these are people who, not necessarily elderly, but maybe say 50 years old, diabetes, emphysema, other health care conditions. They may be homeless, may have nobody to live with, and they don't take care of themselves. They don't take their insulin. In and out of hospitals, the emergency rooms 2 or 3 times a week, which is expensive and inefficient care. We spend a lot of money on those kind of people. The point of this article was that a physician actually, for some reason, he was kind of between jobs. He took one of these people under his wing. He just kind of became his healthcare aide, made sure he got his insulin, he did things. So the physician kept the patient out of the hospital, which saved the system a lot of money. That made the patient better. But it's very labor intensive, and you can't really pay physicians to treat individual patients. But he's trying to develop a system for that. So it's worth reading. So this brings us to the introduction to the Affordable Care Act. I just like to put this one here. What's interesting is the state of Massachusetts, I'm sure we all know the state of Massachusetts, when Mitt Romney was the governor, I believe there was a Democratic legislature, as I understand it, but Romney proposed this plan developed by the Heritage Foundation, which is kind of a Republican agency. And so basically, some of the ideas that they introduced is the individual mandate, which means individuals have to be covered. The concept of exchanges, which we're all reading about now, because they just went into effect the 1st of October, and the expansion of Medicaid, which is important because the Supreme Court threw this one out of the Affordable Care Act. And it's interesting how your party, I guess, depends on how the Heritage approaches. When Romney proposed the individual mandate, it was great. Obama, not so much. It was actually unconstitutional. Insurance exchange is great. Obama's idea of exchange is terrible. Medicaid expansion, good idea, not so good. So the politics kind of get in the way. Well, I thought I was, so the rest of this we'll talk about the Affordable Care Act. So here's the first real part of the act. The first 20 pages, actually I read the act. It was really good, which is sleep. But the first 20 pages is kind of an index, but this is the beginning. So we start here with the title 1, you read this, subtitle, read this, and you get down here. When we start reading here, Part A of Title 27 of the Public Health Service Act, 42 U.S.C. 30 GDP, is amended by striking out the following. And then there's some quotes here. Then you redesignate this and this and this and this. When you get down here, you say, what did we just do? You know, and then you read this kind of legal jargon here. I saw this the other day in the New York Times. The article was about the problems the exchanges were having, and somebody wrote in about, here's the jargon. If anybody can make sense of this, let me know this. I lost it. In the case of the calendar year beginning after 2016, the applicable dollar amount will equal to $750, increased by an amount equal to $750 multiplied by the cost of living adjustment. Pretty soon here. So, but what's it do? Well, it has their title, and what they call title sections. Most important is probably the first one, where to reform of private health insurance, the individual mandate we just talked about, which means everybody has to be in. Subsidies for people who have low income, guaranteed issue that has to be covered, and what the employer responsibility is. So, once everybody needs to be enrolled, the theory here is, if we're a large group, I'm not a statistician, but if you sort of take people that don't need a certain service out of the group early and then they need it, they haven't been paying into the system, and so you're really going to skew the results. And so what the goal is here is to get everybody enrolled. And there is both encouragement to enroll and discouragement to not enroll, meaning that there are subsidies if you need money, and if you don't enroll, there actually potentially can be fines. In exchange, this is what just started a week ago. What these are either state or federal government-run programs where insurance companies submit bids on patients for certain conditions. Well, these are the premiums, this is whatever, the way the insurance companies work. But the governments, neither the state or the federal government, is actually telling the patients what to enroll in. They're not telling the insurance companies what to do. They're simply facilitating a service instead of, a broker, a private broker. The states and the federal government are running these. But I forget, something like 20 states have set up their own exchanges, and the federal government is supposed to do the rest. I'm sure all of us know that that's not a success, at least not yet. So the Act also has businesses between individuals, small businesses, large businesses. Individuals have a certain mandate, small businesses have a mandate. These are less than 50 employees. The large businesses have their own way of being dealt with. So there are supplements here to pay premiums for individuals depending on their level. And if you don't comply, then this is done through the IRS. They look at your salary. There can be fines if you choose not to cover. And some people may choose to do that for their own independent pay fee. Small businesses have their own set of rules, fines for no coverage, and there are 15 different exemptions that can be granted. They're small organizations, they're charitable exemptions, or whatever. Large businesses are different in the sense that they can be fined if they don't cover their employees, but they're treated differently if their plans have been in existence since before 2010, which I think most businesses, large businesses, that's going to be true. And so maybe 6 months ago, the Obama administration decided they would defer forcing these people into the Obamacare Act for another year, but in essence, even when they're in there, it's not going to make much difference because most of them will be grandfathered in. When you go through the Act, they talk about bronze, silver, gold, platinum. This relates to the degree of co-payment and or the percent of the bill the insurance company is going to pay. The less the patient pays in up front, the more that these things are going to be, the more they'll have to pay out of pocket later. So people are going to have to decide for themselves what kind of policies they want. they will no longer allow insurance companies to deny patients for pre-existing conditions. And which is, of course, again, they say, my patients are this, why every one of my patients has a pre-existing condition. And adult children can be covered under their patient's insurance up to age 26, which we already used. My son was 25 when the act went through, and he was working a job and had no insurance, so we could keep on our policy for a year. So again, the other titles, there's an extension of Medicaid to low-income Americans. Supreme Court, in the case threw this part of it out. I only realized a couple of days ago, reading what the impact of this is that if a patient in a state meets federal requirements for Medicaid, then they fall under the state Medicare guidelines. Well, if the state has decided they're not going to fund Medicaid, which more than half the states decided, these people are all lucky. They don't qualify for help under the Affordable Care Act, except in very limited conditions. And since the state isn't funding Medicaid, they don't qualify for Medicaid either. Title III, reform the U.S. medical care system. For example, improvements in the electronic medical record. There's some money there set aside for people to work on to improve the medical record. Independent payment advisory board has been set up for Medicare. I'll talk about that in a few minutes. Title IV, prevention, wellness, and public health initiatives. This title relates to trying to develop and improve the workforce, physicians, nurses, physical therapists, social workers, etc., both in terms of the quality of education and number and the service that's expected of these people. Title VI, fraud, abuse prevention, transparency, regulation of drugs, community living assistance. For some reason, I didn't quite get into the politics of this, but this was repealed. I think it was felt that for what it provided, the expense it was just too large and it was not worth it for that. This is an irony here. Notice the revenue measures to pay for about half the cost of the ACA. Again, I heard on the radio that the Republican drive to shut down the government, this is immune. So the money's already set aside for that. So even if the government shuts down as they wish, they kept trying to defund the measure. This is here. And if it goes on, you know the rest of the government functions at a different level. This title also penalizes insurance carriers for if their costs exceed 20%. In fact, they've already refunded about $1 billion, mostly to employers. I got a thing from the White House about how they were giving money back, but it turns out when you look at it, the individuals don't pay their premiums. The employers pay the premiums, so they're the ones who get the rebates. And then Title 10 is just some kind of TV. So myths, well, the first myth, the one that always drives me nuts, is the death panel ones. This was based upon an initial proposal that was going to fund physicians to have discussions with the patients for advanced care directives. Everybody here got advanced care directives, I hope?
Oh, yeah.
You know what they are? Advanced care directives are, if you know, at some point, and that is probably any age from day one, if you think you're not going to be competent to make medical decisions, you have a stroke or you're unconscious, you need care, you need we as physicians need some way to decide what the patient wants. There was a case with that at the Shiao movement a few years ago. So what an advanced care directive is, it's a legal document that you draw. I and my wife, we each have directives for ourselves. She makes decisions for me, I make decisions for her. And our kids are involved because if something happens to both of us, somebody's going to need to look into directive care. So eventually, I think with Sarah Palin, we talked about how this is a death panel. They're trying to kill these old people. And Charles Grassley talked about throwing grandma under the bus. And so it got to be, it just got to be too politically difficult. So it was taken, it's not, this thing about the advanced care is not in the act. And then I mentioned the independent payment advisory board, which, again, the idea is this will lead to the myth. I suppose it could lead rationally, but specifically in the act itself, on page 370, you can look it up. This proposal shall not include any recommendation to ration health care. The idea is that if Medicare, and it's Medicare, not private insurance, if Medicare expenses increase something like 8% a year, they can convene this group of individuals. As it's pointed out, they're not elected bureaucrats. But they're supposed to be experts in the field, and the goal is not to ration health care, not to limit care, but to see if there are other ways they can provide services to people that will help reduce their medical expenses. Again, as in the case of the guy I talked about who didn't take care of himself and was in and out of emergency rooms, this is a way you can develop care for him. It's said that this will be a job killer. This came from a finding by the Republican National Committee about certain number of jobs have been lost in the month, which wasn't quite true. But even if you believe that number, the number from the year before that, when the Affordable Care Act was in, it was even higher than it was at the time they decided this. It said this will explode the federal deficit. Again, I don't know if you can believe the Congressional Budget Office, but you got to believe somebody. But with all the attempts of the Republicans to repeal the act, the Congressional budget has estimated that if the law is repealed, the deficit will actually increase by about $20 billion a year. This is what was really interesting too. When I first heard this, that Congress is exempt, I had read the act and I thought, I think that's not true. In fact, when you go in there, Congress is specifically covered on page 65. Congress has to use the exchanges to get their medical care. The federal government's no, they're not part of the federal government. But that's where it ends. And what happened recently is somebody said, well, who has to pay for this? Do we pay for ourselves? So the Obama administration decided they would reimburse the employees 75% of the premiums. Well, then this became a big deal because now this is a special subsidy. Looks to me like employment-based insurance. Only most people who have jobs, their employees pay for them. Their employers pay for them. Congress, the federal government is these people's employer. The 75% really is special subsidy is their employer-based insurance. And there's an ad I've seen online, I haven't actually watched it, about the Uncle Sam between you and the patient and the physician. And it kind of looks like a kind of gynecological exam, and Uncle Sam pops up in the middle. Well, Uncle Sam really has nothing to do. Well, they provide money for the exchanges, but the federal government is not dictating to people where they have to receive their insurance and how it's done. Once the insurance is engaged, it's the same as what we have now.
How's that determined?
What's that?
How's that determined? I mean,
What?
that certain physicians aren't in a plan.
Well, the plans make contracts with the physicians. And so, one of the problems with this thing now, and the problems that we're dealing with now, if, for example, you have insurance, you're happy with your insurance, you're a physician, and then for some reason, let's say your work decides they're not going to contract with this plan anymore, we're going to contract with Kaiser. But that means you have to go to Kaiser.
Not to take you on subject, does that go back to the HMOs and PPOs?
Yeah,
That's how the contracts are established.
it's the way the insurance industry works.
Two networks.
So, although Mr. Obama said you can keep your doctor, there's kind of an asterisk there. If your insurance doesn't change, then you keep your doctor. But if for some reason your insurance changes, they may not cover your doctor anymore because that person may not be covered by that plan. I got this on this email list here, a big thing. 6 of 10 Americans may get coverage for less than $100. Now, whether that's a fact or a myth, I have no idea. We tried to figure out, a lot of the Affordable Care Act is pretty logical, pretty simple, but trying to figure out these exchanges, I have to say, is pretty difficult. And I think I'm not sure it's worth the effort in the sense that it's going to be different for every individual. It's like, there are just so many different options. Could be 6 of 10 of us get insurance for $180. Oh, I don't know if that's going to show up. But what I thought I'd do is another rule. I'm almost done, for those of you who need to wake up, I guess. But I just thought I'd better do a little audience participation again, just to see how we feel about this. So the people like the no penalty for pre-existing conditions, just like, so I call it either a feature for Vermont or a bug. Good idea, no penalty for pre-existing conditions, or should we just let the market decide? If you're more of a hard defect, you're on your own. Thoughts about that?
I like the no penalty.
Okay.
No penalty.
So can I just
Yeah.
point on here? It's like what you're leaving off is things like Mrs. Whaley has to get maternity care. in her insurance plan. She has to pay her insurance plan, it's not up there. There's this whole bureaucracy, I think that the real resistance to Obamacare, affordable care, is the whole bureaucracy that comes with it. I mean, the expansion, say, of just the DRGs alone, the diagnostic group coding, have gone from about 300 plus to thousands.
Frankly, I don't know when it was ever 300. I mean,
Pardon?
it was always thousands.
Pardon?
I don't remember when it was 300.
It was, prior to this, around 300 different diagnostic.
No, I mean, going back, I'm not pressing full-time anymore.
Right.
But back in the 1980s, it was 10,000 or something like that.
Diagnostic related
Yeah.
groups? Because I don't know when I dealt with it, like about 300, but anyway, now we've got thousands and thousands, we got 6 of them for duck accidents. I mean, for a duck bite, a duck running into you, I mean, and the one I always loved was, slipping and falling in a museum. It's separate from slipping and falling on the street. I mean, it's...
Careful Sunday.
I mean, you know, I think
These
I
are
understand
things
what
that
you're
I think
saying.
people really kind of look at and say, it's like you mentioned Medicare and Medicaid reimbursements. What you don't mention is it takes sometimes 2 and 3 years to get that reimbursement, and usually it's negotiated down even further. I mean, I don't know about your experience with it, but I know that in California...
Medicare, on a personal level, Medicare has been my easiest insurance plan to deal with. You saw those bills, I had nothing to do with it. I've never received a bill from the hospital.
Okay.
In terms of DRGs, that's not the Obama insurance, that's the insurance company.
The insurance companies came up with the government's
Oh, yeah, absolutely.
list?
Yeah. Well, that's it. Well, I don't know who actually made that list. It's not Obamacare. Literally, there were I think it was 10,000 DRGs.
It's more
But
than
notice,
that.
what the DRG is, it's called a diagnostic related group. And what that means is, if somebody comes in with a disease, it'll take so many doctor visits, so many procedures, so many shots, etc. It turns out, so then you can quantitate that. So if somebody comes in with a kidney condition and it takes X amount, and somebody comes in with a bowel condition that takes the same X amount, they're put together. It's not the disease itself, it's how much resources diagnostic resource groups, it's how much resources they use. But no, it's literally tens of thousands per one, and that's nothing new. That goes back to the 1980s.
I remember back in the 80s, there's only about 300 that I can recall, 360, I think, basic diagnostic related groups.
No, it's-
And the other thing is Medicaid and Medicare doesn't pay for dual care. Like you go in the hospital with a pulmonary condition and you have a heart condition, you only get paid for one
Well,
in the hospital. I'm just saying that the whole system, as it is before Obamacare, was not good.
Well,
The system with this is just looking like another massively bureaucratic payment, and I don't have the answer, but I'm quite sure that in many ways that this isn't it. I mean, that's just...
I won't disagree.
No,
frankly.
I'm just saying,
Can I just, I'm a simpleton. I'm very much a simpleton when it comes to these matters. I have a family member, 40 years old, had cancer 10 years ago, disabled, unable to work. In fact, not even registered with Social Security, totally living off parents at 40 years old. This person, it reminds me of a joke, and I apologize to our conservative members, but a joke that came up where the Republican health plan was don't get sick, and by the way.
And even further, if you get sick, just die.
And I know there's layers and layers of complexity on both sides of the argument, but my question is if you have a person like my family member who's uninsured, handicapped, 40 years old, and is actually literally no Social Security coverage, absolutely on a very, very low income from parents, if that family member gets sick and has to go to the emergency room, and let's say at the emergency room let's say it's a recurrence of the cancer that this person had 10 years ago, what is this person's recourse to care, or is it to die?
No.
Well, in theory, those are the kind of people that this act is supposed
Yeah,
to
but aren't hospitals required to take emergency cases like this?
Hospitals are required to, yes, they can't turn them away. If it's emergency, they can't turn them away. If they deem it, somebody comes out with a cold, they don't have to be seen in emergency. But if it's true an emergency, they have to be taken care of until it can be transferred to a place that will accept an uninsured patient.
Back when you were talking about reimbursement costs, the difference between what a hospital charges and what Medicare and Medicaid reimburses, isn't the difference between those two tax deductible to the hospital?
You're right about
It's
the
seen as
taxes.
charitable contribution and charitable work.
I'm
Most hospitals,
sure that I don't, to
taxes
be honest, I
in.
don't know.
It depends upon the kind of hospital. If it's a non-profit or something like this, that it's a wash. I mean, patients with insurance and patients out of pocket pay for whomever doesn't, whatever Medicaid doesn't pay. I mean, it's economics 101.
I kind of liken this whole conversation to listening to a Catholic mass in Latin. I can understand
We,
bits and pieces of it, but part of it's hidden from you.
Yeah, there was always a
Things where we didn't have to worry about conversation phase.
Okay, well,
I got a question. On the emergency room,
yeah.
could you compare and contrast the emergency room in the U.S. to Canada?
I don't have the.
Yes, I was told that in Canada, somebody there has to be a link to,
Well, we cannot turn, the emergency rooms cannot turn patients away for emergencies. They have to be treated, stabilized, and they can be transferred at if they can find a hospital who will take them, then they can be transferred when they're stable, they can be turned away, even if they don't have insurance.
in Canada,
At least that's the
same
law.
thing, except they have to have somebody to be responsible for part of the expenses.
They don't make somebody else, here they don't make, the patient's responsible. I mean, the patient goes bankrupt, it's not the extraordinary life, or whatever, it's the patient who's responsible.
In some areas in the States, what's happening is, if you don't have any documentation whatsoever, then you need,
Then
they abuse it by going to the emergency room, saying they cannot turn it away. So in some areas, the county is bankrupt because of the bills that the emergency room racked up.
Right. Medical care, as I said, medical care is a significant cause of bankruptcy in the U.S. So I don't know, we can either, I was just going to kind of go through a little sort of audience participation. Should we just skip on? I just have a couple more slides after this.
Okay, yeah, a couple more.
So I like these first three conditions, basically. I'm somewhat ambivalent about forcing the employer mandate care. When we get down here, I have a little point about execution of the exchange. I think has not been very good so far. Although incentive doesn't matter. If they get things straightened out in the next couple of weeks and things work, that's going to be the important thing. And I personally like the idea of a single payer. We've talked about this already, and I'm just going to say in summary, there are a number of problems in the U.S. with human health care. It's expensive, not particularly good outcomes. Many uninsured have an increased mortality, some of them go bankrupt, and the Affordable Care Act is basically just a pamphlet. So I call it Obamacare. We'll solve these problems, and we'll see. It's probably not perfect, but it could be a start, or maybe it's a Kenyan-inspired Marxist.
So if a person goes to the emergency room, but an uninsured person,
Yeah.
they go to the emergency room, just so I understand, they are required to get,
The emergency room legally has to see them.
but let's say,
But they don't have to keep them in the hospital. They can stay with them. I mean, in theory, and it's not so much true, but when I was in medical school, there were big inner-city hospitals that were supported by the taxpayers. And those people were often used by medical schools to get patients for teaching purposes. But those aren't as important as they used to be. But in those days, if you had no money, you went to the teaching hospital, basically, so you became a guinea pig for medical students. That's not done as much anymore, although there still are city hospitals. For example, where we are, Stanford's a private hospital, and it's very, it's Stanford University, they're very conscious of the dollars. They don't really expect that they're going to take care of you. They expect that you are going to give them a huge pile of money so that you can build a building. So if you come in with no money, they'll take it, but as soon as they can transfer you to a local county hospital, you're out of there. But they have to take you, they have to admit you, stabilize you, and then if they can't find a hospital, they'll have to take care of you until they can find somebody else. But they legally are supposed to do that. Now, there have been lawsuits about that. There was a patient, I think the Kaiser patient in LA, that was, it was made difficult, but it was, I can't remember if they got sick or died, but the family sued Kaiser and won a fair amount of money. Sorry.
I have a neighbor who works at Harvard Hospital as a physician, delivering babies. This year, he said they'll deliver 24,000 babies to that hospital. 80% of them will not have insurance. And the hospital will get nothing. It's the department hospital, it's the county hospital, the charity hospital for. But they'll deliver 24,000 babies in 1 year in the numbers a day. And they get nothing, 80% of it. And he said after Obamacare is fully implemented, they'll still get nothing. Because these people are immigrants without papers.
Well, that's the Congress.
And we have constant charges about suburban hospitals or caring for patients. They're hiring an ambulance to take them down there to have a baby. Their healthcare system is suburban hospitals all over the Dallas area. And they're sending, all the hospitals are sending out their indigence department. And the department's trying to tax the various counties who are doing this.
My charge is to be the grim time.
I think that one more thing. My wife runs the free clinic in our town. And because of Obamacare, they have to start charging, actually charging the government. But they have to all this paperwork. And a lot of doctors, nurses, are quitting because, it's all of a sudden become this free clinic and now become a bureaucratic nightmare. And I'm just, throwing that in.
Well, was it working well before?
Pardon?
Was it working well before?
Yes, absolutely. It was, the town supported it, financially, the doctors volunteered, the dentists volunteered. Now they can't unless they're approved, and there's just all this paperwork, and they have to start charging whatever federal institution, Medicaid, somebody, for their services.
Well,
no longer a free clinic.
Again, there are exemptions for some of these things, and it may be that there's a way they can
what I'm saying is that I think the bill is very fully written, not just thousands of pages.
It takes a long time to do this.
Pardon?
It's only 906, my version. That doesn't include all the references.
I understand.
One final question from Lois, and then we'll move to David.
I just wanted to mention that having studied this vaguely, for years at home, I was absolutely flabbergasted when the administration took single payer off the table. It wasn't even on the table to begin with, because they went with this Romneycare style thing that the Heritage Foundation had once accepted, and now everyone is saying no, but they should have considered, at least considered single payer at the beginning.
I agree 100%. My take on it is that Mr. Obama was a realist, and he realized he would never get single payer through Congress.
Yeah, but he should at least have put it on the table.
Well, I think in retrospect, I think he thought, and in retrospect, that this was a Republican plan.
Yes, he thought it was a
How could the Republicans
Republican.
vote against it? Well, it turns out, as soon as you say Obama, the Republicans are against it.
Yeah.
And I don't think he really anticipated, but individually. This actually starts in Seattle.
Really? Is that Helen and Martin?
It's Lenin. Some Seattle guy was in, Ukraine, and there's a statue.
Oh, and he brought it home?
We paid like $150,000.
Thank you so much.
Thank you all for listening.
No, it was incredibly informative, and 1 minute. I know we're already significantly behind schedule. We have a long line.
Central Asia.
Okay, thank you. No problem at all.
I didn't think of that, I just said, okay,
If it's any comfort, in 2009, we got hours behind.
That's when it's 4K?
That was 2011.
We'll do a few minutes recess, John?
there, I don't know what.
For 1 minute.